1. How to get your employer to cover GLP-1 drugs save on weight loss medications. 2. Wegovy and Zepbound price drops. What it means for access to obesity drugs in 2025. 3. Major insurance changes impacting GLP-1 weight loss drugs. What patients need to know. 4. CVS Caremark drops Zepbound. Weight loss drug coverage ended. 1. How to get your employer to cover GLP-1 drugs save on weight loss medications. Are you frustrated by how difficult it is to actually access the revolutionary GLP-1 medications, despite all the life-changing potential they offer? If so, you're not alone, and the obstacles go much deeper than most people realize. But here's where it gets controversial. Most insured Americans simply can't get these breakthrough drugs covered at all. GLP-1 drugs, which have dramatically transformed how we fight obesity and conditions like diabetes and heart disease, represent a crucial leap forward in medicine. Yet, ironically, the majority of Americans with health insurance find these medications out of reach, thanks to the complexities of our current system. Some individuals have resorted to using compounded versions of these drugs, formulas not vetted by the FDA for safety, often sourced from overseas manufacturers that lack the stringent quality controls required for FDA-approved products. But even this risky alternative is vanishing. The FDA has recently made it clear, now that the supply of name-brand GLP-1 drugs has stabilized, off-brand compounded options are no longer permitted. So, what's left for patients desperate for help? The issue of cost looms large. Former President Trump recently waded into the debate, demanding that pharmaceutical companies offer Americans the same prices as other developed countries. He pointed out that while a friend in London can access these drugs for about $150 a month, US patients are staring down bills of more than $1,000 a month. These numbers are eye-opening and infuriating for many. But here's the thing. Congress hasn't yet forced manufacturers to offer lower prices on prescription drugs in the United States. Yet, there is a practical path to making these medications far more affordable for millions of everyday Americans. Let's break it down. Most working Americans get their health insurance through employer-sponsored plans, which rely on a pool of premiums paid by both the employer and employee. For now, the vast majority of these plans don't cover weight loss treatments at all. If they were to start covering GLP-1 drugs, the extra expense would have to come out of that same pool, which could mean higher premiums for everyone. Is that a price we're willing to pay for broader access? It's hard to overstate the stakes. Excess body fat causes a host of chronic conditions, and GLP-1s can help people regain control of their health. With studies showing that nearly 9 out of 10 US adults are metabolically unhealthy, the need is overwhelming. More and more employees are pressuring their employers for coverage, and many companies are listening. There's a fascinating twist most Americans have missed. Drug makers actually offer their GLP-1 products directly to patients for about $500 per month. Sounds better, right? Not so fast. Anyone with employer-sponsored insurance, even if their plan won't pay for these drugs, is disqualified from that lower price. Plus, for many, $500 per month is still out of reach. US drug pricing remains notoriously opaque, with countless middlemen pocketing slices of every dollar. Typically, a $1,000 drug passes through a maze of rebates, often $300 or so, negotiated by pharmacy benefit managers, PBMs, on behalf of your health plan, and manufacturer coupons, maybe $150. At the end of this complicated math, the price is often not far from that $500 direct-to-patient cost. But few consumers ever see these savings. Imagine a simpler system. Eliminate all the confusing rebates and coupons. If manufacturers simply charged employer health plans the same $500 price they advertise to the public, and if employers covered a reasonable portion, say $300 per month, employee out-of-pocket spending could finally fall in line with what patients in Europe pay. No shell games, No hidden handouts, just affordable access through honest cost sharing. Here's the underlying controversy. The system of rebates and discounts isn't about patient health. It exists mainly to let certain manufacturers cut deals with PBMs and insurers, steering coverage their way and locking in market dominance. But why do we need all this maneuvering when only 2 major GLP-1 products are available, and their effectiveness is easily confirmed by public clinical trial data? The answer exposes a system where profit often trumps patient needs. Worse still, this tangled pricing structure fuels one of the most hated features of American healthcare: prior authorization. Doctors and staff spend precious hours fighting pointless paperwork to get patients drugs their physicians say they need. Wouldn't we all rather see those resources spent on care? Now, make no mistake, while GLP-1s work incredibly well for many, they do carry real risks. Deciding whether the benefits outweigh the downsides should remain a personal conversation between doctor and patient, not a cost-driven decision by insurance bureaucrats. And this is where the national conversation could ignite even more debate. What if government programs like Medicare helped foot the bill? The Biden administration took steps to include GLP-1s under Medicare, but President Trump reversed this policy earlier this year, barring both Medicare and Medicaid from covering them for obesity. Should taxpayer-funded health programs help cover these drugs, especially given their potential to reduce long-term healthcare costs? While such reforms won't fix every problem with skyrocketing drug prices, making GLP-1s widely accessible could be a pivotal first step toward better public health and a saner, more equitable healthcare system. So, what do you think? Should employers and the government work together to bring GLP-1 drugs within reach for more Americans, even if it means reshuffling health insurance budgets or raising premiums? Or should the focus be on forcing manufacturers to simply lower their prices? And for those skeptical of expanding drug coverage, are there other solutions the country should be considering? Share your perspective. This debate isn't going away, and your voice matters. 2. Wegovy and Zepbound price drops. What it means for access to obesity drugs in 2025. Imagine you're finally seeing some relief in the sky-high prices of Wegovy and Zepbound, 2 popular medications for obesity. But here's where it gets tricky. While the costs are coming down, getting consistent access to these drugs is still a significant hurdle for many. These treatments can still cost around $500 a month for individuals without insurance, putting them out of reach for numerous patients. Even those with insurance face varying levels of coverage, making it a patchwork system at best. The challenge isn't just the availability of these medications, it's also about affordability and sustainability, explains Matt Majewski, a professor at Duke University who specializes in obesity treatment coverage. Doctors across the board agree that they have to think creatively to treat their patients effectively under these conditions, but there's optimism that prices could continue to decrease in the future. Wegovy and Zepbound are part of a growing class of obesity medications called GLP-1 receptor agonists, which have seen a surge in popularity due to their efficacy. For instance, Zepbound generated $2.3 billion in sales during the first quarter of this year, becoming one of Eli Lilly's top-selling drugs. Similarly, Wegovy, manufactured by Novo Nordisk, has garnered approximately 200,000 weekly prescriptions in the US, racking up nearly $1.9 billion in sales during the same period. The benefits consultant Mercer reports that an increasing number of large businesses, specifically those with 500 or more employees, are now offering coverage for these injectable drugs for their workforce and their families. Additionally, Novo claims that 85% of its patients in the US with insurance pay $25 or less per month for their medication. Furthermore, patients with diabetes may be able to secure coverage for GLP-1 drugs like Ozempic and Mounjaro, which are approved for diabetes management. However, the majority of state and federal Medicaid programs do not cover these medications for obesity, nor does Medicare, which primarily serves individuals aged 65 and older. Even when coverage is available, it often doesn't cover the entire cost, leaving patients with substantial out-of-pocket expenses. Dr. Beverly Chang, a physician based in New York who advises both Novo and Lilly, emphasizes, e-coverage is not the same as access. Employers and pharmacy benefit managers, PBMs, are wary of these medications due to potential long-term use by many employees. As a result, some large employers have opted to discontinue coverage, and PBMs are increasingly favoring one brand over another during negotiations with drug makers. One notable example is CVS Health's decision to remove Zepbound from its national formulary in favor of Wegovy on July 1, forcing Dr. Beverly Chang to develop alternative treatment plans for her patients who preferred Zepbound due to fewer side effects. Dr. Courtney Younglove, an Overland Park, Kansas-based physician, encourages her patients to check their insurance coverage online before their appointments. Unfortunately, many patients cancel their visits when they discover that their insurance doesn't cover the medications. During periods of drug shortages, compounding pharmacies were permitted to produce cheaper, off-brand versions of Wegovy and Zepbound. However, the FDA declared the shortage over earlier this year, officially ending the production of these compounded versions. An exception exists when a drug is personalized for a specific patient, as seen with Hims and Hers Health, which offers customized doses of semaglutide, the active ingredient in Wegovy, to help manage side effects. These plans typically start at $165 per month for a 12-month supply, with upfront payment required. This practice has sparked controversy, with Eli Lilly suing various pharmacies and telehealth companies for producing compounded versions of their products. Recently, Novo terminated its partnership with Hims due to continued compounding practices, citing concerns about patient safety and unregulated foreign suppliers. Hims maintains that it adheres to U.S. quality and safety standards and verifies drug potency through third-party labs. Despite these challenges, both drug manufacturers have reduced their prices for uninsured individuals to around $500 per month, a slight decrease from initial rates. Nonetheless, this cost represents approximately 14% of the average annual per-person income in the U.S., which is roughly $43,000. Factors such as the development of pill versions of these treatments and increased international competition may help drive prices down further. Dr. Younglove anticipates price wars leading to reduced costs, noting that we're in the early stages of this process. In conclusion, while the prices of Wegovy and Zepbound are gradually decreasing, ensuring consistent access remains a significant concern for many patients. The journey towards affordable, widespread availability continues, and the healthcare community is closely watching how these dynamics evolve. 3. Major insurance changes impacting GLP-1 weight loss drugs. What patients need to know. Imagine a world where the medication that has become a lifeline for managing your weight suddenly becomes unaffordable due to insurance changes. This is the reality facing many patients, including Tara Ikobakai, who recently discovered her health insurer would no longer cover her GLP-1 drug, Zepbound. But here's where it gets controversial. These changes are being driven by pharmacy benefit managers like CVS Caremark, who claim they are promoting competition to reduce costs. And this is the part most people miss: the impact these decisions can have on patients' health and well-being. Last week, Tara had a doctor's appointment dedicated entirely to insurance issues. Her frustration is palpable. I'm completely outraged. It's not only causing me stress, but it's making me angry. Starting June 1, 2025, CVS Caremark will stop covering Zepbound, a GLP-1 drug approved by the FDA for chronic weight management in adults with obesity or who are overweight. Instead, they will continue to cover Wegovy, a similar medication from competitor Novo Nordisk. CVS Caremark justifies this decision by stating that Wegovy is a safe and potentially cheaper alternative. However, they acknowledge that if patients refill their Zepbound prescriptions after July 1, 2025, they'll have to pay the full price. This move reflects a broader trend among pharmacy benefit managers, who are under pressure to control drug costs. Yet, Critics argue that these decisions often prioritize financial savings over patient needs. The controversy doesn't stop there. The Obesity Action Coalition, a non-profit advocacy group, points out that obesity is a chronic disease requiring long-term management. Dr. Tracy Zvenyuk, Director of Policy Strategy and Alliances at the coalition, explains, "We don't accept obesity as a long-term chronic disease, and we're still looking for quick fixes. The mindsets haven't caught up with the science yet." This misunderstanding can lead to exclusionary policies that hinder access to necessary treatments. Developing an effective treatment plan with GLP-1 drugs involves trial and error. Dr. Jody Dushay, an endocrinologist at Beth Israel Deaconess Medical Center and assistant professor at Harvard Medical School, emphasizes the importance of finding the right medication for each patient. Switching medications can disrupt weight loss progress and cause unnecessary stress. Dushay notes, "Every time there's an announcement about insurance coverage changes, I get inundated with messages from patients who feel their progress is threatened." Insurance considerations also complicate clinical care. Discussing insurance changes during appointments leaves little time for addressing patients' symptoms, weight loss, and overall health. Dushay laments, "There's barely time to ask about how they are feeling." There's a significant time burden outside the visit for both doctors and pharmacists. Another major change looms in January 2025, when BCBS Massachusetts will exclude all GLP-1 drugs from obesity treatment coverage, reserving them for diabetes management. This decision highlights the ongoing debate about the balance between access to innovative treatments and controlling healthcare costs. While Zepbound and Wegovy are both effective, they differ in their mechanisms and side effects. Studies show that Zepbound can lead to greater weight loss and is approved for additional conditions like sleep apnea in obese patients. Patients who have found success with Zepbound may apply for exceptions, but the appeals process can be lengthy and frustrating. Iko Bakai's experience underscores the personal impact of these changes. She successfully switched from Wegovy to Zepbound after proving the former didn't work for her. "The medication validated my struggles and supported my journey," as she says. Losing coverage for Zepbound could undo her progress and exacerbate both physical and mental health issues. Eli Lilly has responded by expanding access through Lilly Direct, offering out-of-pocket options for patients. However, the high costs of these alternatives can be prohibitive. Lilly remains committed to ensuring patients have access to Zepbound, but the broader implications of insurance coverage changes continue to challenge the healthcare system. In conclusion, these insurance changes raise important questions about the balance between cost control and patient care. How can we ensure that innovative treatments remain accessible while addressing rising drug costs? Your thoughts and experiences are valuable in this ongoing conversation. 4. CVS Caremark drops Zepbound. Weight loss drug coverage ended. A major shift in healthcare access is sparking heated debates. One of America's largest pharmacy benefit managers, CVS Caremark, has decided to exclude coverage for Eli Lilly's blockbuster weight loss drug, Zepbound. This move, framed as a cost-cutting measure, has ignited a firestorm of controversy about who truly benefits from such decisions: payers, manufacturers, or the patient's court in the middle. But here's where it gets controversial. While CVS claims this action will save clients 10 to 15% annually on obesity medications, critics argue it risks destabilizing progress for patients who finally found effective treatment. And this is the part most people miss. The real battle isn't just about drug prices, it's about who controls the narrative around medical necessity versus financial incentives. Zepbound, the brand name for tirzepatide, was hailed as a revolutionary treatment after clinical trials showed users losing up to 25% of their body weight. Originally developed for type 2 diabetes, under the name Mounjaro, it now carries FDA approval for obesity management. Yet despite its medical promise, CVS spokesperson Philip Blando declared GLP-1 medications like Zepbound are egregiously overpriced and the single biggest barrier to patient access. The irony? Many insurers, including Medicare, have already refused to cover these drugs for weight loss due to their soaring list prices. But here's the twist. Exceptions will still exist for patients deemed to have a medical necessity, though these will be evaluated case by case, a vague promise that leaves many questioning how accessibility will truly work in practice. To understand the stakes, consider this. As a pharmacy benefit manager, PBM, CVS acts as a gatekeeper in the prescription drug ecosystem. These middlemen negotiate prices between pharmacies, insurers, and manufacturers. Yet pharmaceutical giants like Eli Lilly have long criticized PBMs for prioritizing rebates over patient care. Lilly recently stated that lowering drug costs for Americans requires intermediaries taking less for themselves. Now, with CVS's decision, the tension between financial pragmatism and medical ethics has never been sharper. Dr. Christopher McGowan, an obesity medicine specialist, called the move deeply disruptive, noting that switching medications mid-treatment can undo progress, trigger weight regain, or introduce new side effects, even if alternatives are still effective. The controversy goes beyond Zepbound. McGowan warns this decision reflects a dangerous trend where financial contracts between PBMs and manufacturers are shaping clinical decisions. Patients, he argues, are losing choices not because of medical guidelines, but because of behind-the-scenes rebate deals. Once a patient finds a working medication, preserving that success should be the priority, he insists. Instead, we're seeing progress disrupted by decisions patients never asked for. Eli Lilly, meanwhile, is pushing back. The company claims it's committed to ensuring access by expanding its self-pay program, LillyDirect, which offers Zepbound at $500 per dose for uninsured patients. But this solution raises its own questions. Should patients have to pay hundreds per month out of pocket for a drug their insurer once covered? And what happens when financial barriers force people to abandon treatments that could literally save their lives? This situation forces us to ask, when cost-cutting clashes with medical advice, who should hold the reins? Should pharmaceutical companies shoulder more responsibility for pricing, or is it time to rethink the role of PBMs altogether? Share your thoughts in the comments. Do you believe financial incentives should ever override clinical judgment, or is this a systemic failure in how we value healthcare?